Hello everyone, so today we're going to talk about the lower digestive tract, and this is chapter 39 of your book. The lower digestive tract, it consists of the small intestines, the large intestines, which we call the colon, the rectum, and also the anus, and they all play a critical role in digestion, just like the upper digestive tract that we talked about in chapter 38. So in terms of the lower digestive tract, the role that it plays is mostly in the digestion piece, is in terms of the absorption of nutrients and also the elimination of the waste once we have ingested all of the nutrients that we can from the food that we eat. So some of the key features or key functions that we're going to talk about, we're going to talk about the small intestine, which is composed of the duodenum or the duodenum, which some people call it different names, the jejunum, and also the ileum. And this is the primary site for that nutrients absorption. The small intestine, it does contain what we call villi and microvilli, and they help increase the surface area in the small intestine for that absorption to occur. In terms of the large intestine, which we'll learn is the colon, which is broken down into different sections, the ascending, transverse, and descending, and also the sigmoid colon. It's mostly going to absorb water and also electrolytes in order to help form and store feces before we eliminate it. And the last portion of the lower digestive tract that we'll talk about is the rectum and the anus. And the rectum basically serves as a storage site for feces, and of course the anus controls the expulsion of the waste through sphincters. Again, it controls when that waste can be released. So some other things that we're going to talk about in this chapter are in terms of their clinical significance of the lower digestive tract. So some of the disorders that could occur in the lower digestive tract include things such as Crohn's disease, ulcerative colitis, diverticulitis. Also, a patient may have colorectal cancer, and also IBS or irritable bowel syndrome. And some of the things that we can use to detect these disorders are things such as barium enemas, which is an imaging exam in X-ray. They can have a CT scan, and they can also, one of the earlier diagnostic procedures is a colonoscopy. They can use that as well to help diagnose some of these conditions. So again, this is your lecture on the lower digestive tract. All right, these are our learning objectives. So we're going to discuss the size, position, divisions, and the wall of the small and large intestines. We're going to locate and discuss the significance of the variform appendix, discuss the peritoneum and its reflections, and we're also going to discuss the structures and functions of the liver and the gallbladder, explain the relationship between cell types and their functions in terms of the pancreas, and also discuss disorders of the lower digestive tract. All right, so the first thing we're going to talk about is the small intestine. So the small intestines is, again, a component of our digestive system, and it's responsible for the majority of nutrient absorption. So the small intestine is considered to be a long coiled tube. So it's basically coiled up, like let's say a snake coil or even a water hose coil is in a coiled fashion. And of course, it measures approximately 6 meters in length, and in terms of the diameter, it's about 2.5 centimeters in diameter. All right, the small intestine does allow, again, for digestion and absorption through specialized folds that it has, and also villi and microvilli. So the divisions of the small intestine that are listed here is the duodenum or the duodenum. That's the first portion of the small intestine. It's also the shortest portion or the shortest section of the small intestine. It's approximately about 25 centimeters in length, and it forms what we call a C shape. So it basically, it also curves around the pancreas. So again, it's the primary site for enzymatic digestion. It's also the site that receives bile from the liver, and it also has digestive enzymes from the pancreas are received there as well. All right, the next section is the jejunum. That's the middle section, and it's approximately 2.5 meters in length. And that's the site where most of that nutrient absorption occurs. So that includes absorption of the carbohydrates, the proteins, and also the fats. One thing that the jejunum is characterized by is by the fact that it has a thicker wall, and it also has folds, and the folds are going to increase the surface area for that nutrients to be absorbed. All right, the last division of the small intestine is the ileum. All right, and the ileum is the longest section of the small intestine. It's approximately 3.5 meters long, and it's responsible for absorbing vitamin B12, bile salts, and also any other remaining nutrients that are left within the chyme. So the ileum connects to the large intestine via what we call the ileocecal valve. So that's like the terminal valve there. And this ileocecal valve prevents backflow of waste, just like we talked about with the esophagus, ensuring that the esophagus is closed off via that sphincter. The ileocecal valve is also a sphincter that prevents backflow of waste as well. So some of the key points again for the small intestine is the fact that it does have coiled loops, and it does fill up most of our abdominal cavity. It is lined with small villi. Well, it does contain small villi and also microvilli, and that helps increase the surface area so that we can have more efficient nutrients being absorbed. And some of the disorders that people may have in this area or that a patient may present with is things such as celiac disease, Crohn's disease, and also you can have small bowel obstructions. And all of these conditions can impact digestion and also efficient nutrient absorption. So again, the small intestine does play a big role when it comes to breaking down the food and also absorbing the essential nutrients that we need. All right, now in this slide, we're looking at basically two imaging perspectives. So one is, of course, a X-ray image highlighting a radiographic procedure, and the other one is a laparoscopic type procedure. So again, both of these are imaging studies that we can use in order to assess the structure and also the function of the small intestine, specifically if we're trying to detect abnormalities like obstructions, tumors, and also inflammation. So this image A is an AP view of an X-ray. For this one right here, as you can see, we can see the stomach in the upper portion, and we can also see that the contrast is now leaving the stomach and is entering the small bowel. So as you can see, the numerous loops of the small bowel. And this is a barium study of the small intestine. We call it a small bowel series. All right, so the barium, which is a contrast media that we use in X-ray, it basically highlights all of these loops, so we can clearly see all of the loops of the small intestine, and it allows the radiologist to diagnose the function of the small bowel. So for this particular image, the patient is positioned in a um, supine position. So they're basically laying on their back on our x-ray table, and we're taking an AP view of their abdomen, all right, to view the small bowel. All right, and again, for this one, we can look at things such as small bowel obstructions. Also, some of the imaging that we can do, we can look for malabsorption type disorders, we can look for tumors, we can look for polyps, and also we can look for things such as ulcerative colitis and also Crohn's disease. Now, image B. This is a laparoscopic view of the small intestine. So basically, we've inserted a scope or a camera, and we're looking real time at the small intestine via that camera. So laparoscopy is, I'll say, minimally invasive. Um, it is a procedure that we can use in terms of diagnosis of certain conditions of the small bowel, and we can also do surgical intervention as well in these laparoscopic procedures. So common indications for a person needing this type exam is basically we might need to explore that abdominal region for pain of an unknown origin, so we're going to visually check it out. Of course, we can diagnose and treat things such as adhesions, tumors, and also hernias as well. And we can evaluate things such as inflammatory bowel disease with laparoscopy. And we can also perform things such as biopsies, so that we can further send it on for histological analysis, meaning we need to send that tissue that we've gathered via the biopsy to the lab for further analysis. So again, these are some procedures that we can use to evaluate the function of the small bowel and also the structure of the small bowel. And we can also do direct visualization and intervention if necessary, specifically if we're talking about this laparoscopic type procedure. All right, now we're going to look at the wall of, or talk about the wall of the small intestine. So again, the small intestine, that's our primary site for digestion of nutrients. So we're talking about nutrients being absorbed, and the structure of it is basically structured in a way so that this nutrient absorption is going to be efficient. So the inner lining of the small intestine contains what we call placae circularis, or folds. And these folds also have villi and also microvilli. All right, and those increase the surface area for absorption. So give us more area to perform that nutrients absorption. So again, these are the structural features of the intestinal wall. So the placae, or the circular folds, they are large folds in our mucosal and also the submucosal layers of the small intestine. And in terms of function, what they do is they slow down the movement of the food, allowing us to have more contact or more time with the chyme for that nutrient absorption. In terms of the villi, those are finger-like projections that cover the placae. So again, those villi, they contain what we call arterioles and also venules and also lacteals. So we're talking about lymphatic vessels that help transport the nutrients that is being absorbed. All right, the microvilli, they further increase that surface area so that we can continue to absorb that nutrient. So they're tiny hair-like extensions that are on the epithelial cells of the villi. And in terms of function, they contain digestive enzymes that are going to help further break down carbs or carbohydrates and also proteins before they are absorbed. So the cell types that we have in our intestinal walls are going to be the enteroendocrine cells. And enteroendocrine cells are found in the villi, and these cells produce intestinal hormones like cholecystokinin. We call that CKC or CKK, depending on which book you read. And this is a hormone that helps regulate digestion. We also have what we call tuft cells or brush cells in this area. And these cells are they're dense tufts of like long microvilli, and they secrete prostaglandins and also endorphins. So they do play a role in immune response and also how our gut functions. We also have crypts in this area, and these are intestinal glands. They're located at the base of the villi, and they contain what we call stem cells, and stem cells help basically produce new intestinal epithelial cells. So they continually reproduce new cells. So again, the key takeaways from what lines the wall of our intestine are a combination of placi, villi, and also microvilli that help increase the surface area of the small intestines so that we can better digest and absorb the food. Now, there are again specialized cells there as well within the intestinal wall that contribute to hormone regulation. Also, they assist with immune defense and also the continuous epithelial renewal. So that is pretty much it for this particular slide. All right, now we are looking at a picture of stem cells that are within those intestinal crypts that we talked about. So the intestinal lining has to undergo continuous renewal in order to maintain that its digestive function. All right, and we also need to continuously renew it, basically to keep it protected from damage that might occur during this digestion process. So the process is spearheaded or driven by the stem cells that we talked about, and they're located at the base of the intestinal crypts, and they're also known as crypts of Lieberkühn. And again, the stem cells help generate specialized cells that we need for digestion, absorption, and also immune defense. So key points again in terms of the location and function of these stem cells, they're found at the bottom of these intestinal crypts, which we see right here. And the cells are constantly dividing, constantly being replaced due to damage or also aging. So again, there's four main types of these cells, and they're goblet cells. And goblet cells, we learned earlier, goblet cells produce mucus to protect our intestinal lining. We also have enteroendocrine cells. All right, and the enteroendocrine cells basically release digestive hormones like secretin and also cholecystokinin. In terms of absorptive enterocytes, they help absorb nutrients and also help digest the food. And then in terms of the tuft cells, they secrete prostaglandins and also endorphins. So they help with our immune response and also inflammation. All right, in terms of the cell turnover process, once the cells become differentiated, or once they grow, they do migrate towards the top of the villi. Of course, they do that every several days, and at the top of the villi, that's basically they're going to shed and be replaced. So again, we're going to ensure that the small intestine remains efficient in terms of digestion and also in terms of absorption. Um, we also have down here, we have the Paneth cells, and they basically move deeper into that crypt instead of migrating upward. And their role is mostly, they function primarily for immune defense. So they more so produce antimicrobial peptides and also enzymes that are going to kill any harmful bacteria that we have within the small intestine. So again, in terms of clinical relevance here, any disruption of these stem cells in terms of their function, it can lead to GI disorders like inflammatory bowel disease. With that, those stem cells, they dysfunction or are not functioning properly, so they contribute to chronic infection or inflammation in terms of things like Crohn's disease and also ulcerative colitis. When those stem cells malfunction, they can contribute to celiac disease, which is where damage to the crypt cells reduces the number of functional cells that can help with absorption, and that leads to a person maybe leading to things like malnutrition. All right, and also in terms of stem cells, if we have any abnormal stem cells, it can lead to things like colorectal cancer. That's when abnormal stem cells, we're talking about mutations in the cells, and that can lead to uncontrolled cell division and also tumor formation. So again, these intestinal crypt cells and their stem cells play a vital role when it comes to maintaining a healthy and functional digestive tract. They also help us be able to continuously replace cells and ensure that digestion is efficient, absorption is efficient, and we also have the appropriate immune protection that we need. All right, now in this slide, we're looking at a microscopic or micrograph of the ileum wall. All right, so with this one, we're looking at the arrangement of the villi. We're also looking at the intestinal crypts, and we're also looking at those Paneth cells as well. So the ileum is the final and the longest section of the small intestine that we pointed out earlier, and it does play a huge role when it comes to that nutrients absorption and also the immune function. So some of the key features here of the ileum wall, we see the villi right here. So these are the finger-like projections that we talked about earlier that are going to increase the surface area for more efficient nutrient absorption. And each villi contains capillaries, all right, and we need that for absorbing sugars. We also need it for absorbing amino acids, and we also have lacteals there for absorbing things such as the fats. All right, we also see here the intestinal crypts of Lybricon here, and those crypts are located between the villi, as you can see, and that's where the stem cells are contained. And again, the stem cells are responsible for regenerating that intestinal lining. So there's also, it also houses other specialized cells that are going to support us in terms of further digestion and also immunity. We also have the Paneth cells here, And the Paneth cells are marked by these arrows. And again, they're found at the base of the crypts, and they play a role when it comes to, it's more of a protective role by secreting that antimicrobial compounds such as lysosomes, and also defensins. So again, it helps regulate our gut health, or the gut microbiome, to prevent things like infections. So in terms of the functional significance of the ileum, that is the final site for that nutrients absorption. So we're talking especially things such as vitamin B12, and also bowel salt. So these are crucial for red blood cell production and also fat digestion. Also, in terms of the ileum does contain what we call pure patches, and those are basically clusters of immune tissue, and they basically monitor and defend us against pathogens that are inside of our digestive tract. We also are rich in goblet cells in this ileum area. And goblet cells, again, they're going to produce mucus to protect the epithelium, and also facilitate a smooth passage of waste from the small intestine into the large intestine. All right, now we're going to talk about the large intestine. So the large intestine is the final segment of our digestive system. So we talked about the beginning portion of the upper digestive system, which we went from the mouth down the esophagus into the stomach. Then we talked about the small intestine. So now we're going to talk about the final segment, which is the large intestine. All right, primarily this section is going to be responsible for water absorption, also electrolyte balance, and also the formation of feces or fecal formation. It is wider in diameter than the small intestines, but it is shorter in length, because the small intestine is many coils. So the large intestine is shorter in length. It measures about 1.5 to 1.8 meters in length, but diameter wise it is larger. It is 6 centimeters in diameter. All right, so as waste moves through the large intestine, it does gradually decrease as we get towards the rectum and also the anus. So the divisions that we see here, it tells us that it's divided into the cecum, the colon, and also the rectum. So the cecum is the first portion. It's a pouch-like structure, and it's located at the junction between the small and the large intestine, and it's connected to the ileum via what we call the ileocecal valve, and that ileocecal valve prevents the backflow of waste. This area also houses or contains the appendix, which contains lymphatic tissue, and it plays a role in what we call gut immunity. The colon is the next section. That's the main absorptive section of the colon. It is further divided into 4 parts, which we'll talk about a little bit later, but just a preview. It's divided into the ascending colon, which moves the waste upward along the right side of our body, and then it transverses across the abdomen via the transverse colon. And again, the transverse colon extends across the abdomen, and then it goes down into the descending colon, which moves the waste back downward on our left side, and eventually it reaches the sigmoid colon, which is an S-shaped portion that connects to the rectum. So again, in terms of function, The large intestine is the location where we're going to absorb water, we're going to absorb electrolytes, and we're going to also absorb vitamins like vitamin K, and also biotin absorption happens in this area. The last area of the large intestine is the rectum. That is the final segment right before the waste is expelled. So the rectum is where feces is stored, and it also triggers defecation. So all the reflex basically that we have when the rectum is full. So again, the key functions of the large intestine, we have that water absorption. So it basically prevents dehydration by reclaiming all of the water from digested food. We also have bacterial activity that happens here in the large intestine. So we have trillions of what we call beneficial bacteria. So we're talking about the gut biome or microbiota, and that gut biome or the beneficial bacteria that's located there helps basically ferment things like fiber, and also it produces vitamins there. And then also this is the area where we have waste formation. So it basically compacts anything that's undigested in terms of the food, and also waste into what we call feces, and prepares it for us to be able to eliminate it. So some things that happen in terms of clinical relevance in this large intestine area, we may become constipated. So constipation happens because we have excessive water absorption due to the slow movement of waste. So the patient becomes constipated and they're not able to use the bathroom. Another thing that could happen in this area is things such as diarrhea. And diarrhea happens because we have basically decreased water absorption, often due to things like infection or some other digestive disorders. So the feces that we have is more watery. So constipation, we can't use the bathroom. Now diarrhea, we're using the bathroom and it's very watery. Also in the large intestine, we may have conditions such as diverticulosis or diverticulitis, and these are formations of small pouches in the colon wall that can become inflamed. So diverticulosis is just the pouches being formed. Diverticulitis is when those pouches become inflamed. And also in this area, we can have colorectal cancer. So that's one of the most common cancers that we often detect when the person goes in for their colonoscopy. So again, the large intestine does play a huge role when it comes to waste processing and also water conservation. So the way that it is structured and also the function of it helps us maintain what we call a good balance of or a healthy gut in terms of digestive health. All right, now here we're looking at a picture of the large intestine and also some of the vascular structures that it houses or that surrounds it. So the large intestine, we already said it's divided into specific regions, and each of those regions do have a particular role when it comes to the digestive and also the absorptive type function that it has. So we talked about the cecum, which is this area. That's the first section of the large intestine. And of course, it connects to the ileum via the ileocecal valve. All right, so the ileum is here. That is where the small intestine ends. And of course, we have the ileocecal valve here where that food can empty into or empty into the large intestine. So basically the purpose or the function of that cecum is to absorb fluids, also salts, and also um, these are things that remain after digestion from the small intestines, because it's emptying from the small intestine here into the cecum. All right, we also said that the cecum contains the appendix, or the veriform appendix. And in the past, we said that the appendix doesn't really have a role, but now we're finding that the appendix does play a major role or a minor role in terms of our immune system. All right, the next section, or the main segment of the large intestine, is the colon. All right, and the colon is sectioned off. All right, so as we can see here, we have the ascending colon that runs upward. This would be on the right side of our abdomen. And then we have the transverse colon, which is the horizontal section that transverses across our abdominal cavity. And then we have the descending colon here, which runs downward on the left side of our abdomen. And then we have this S shape here, which is the sigmoid colon, which is the final section that leads to our rectum right here. So this is the S shape that it talks about. And this is basically where that we're going to reabsorb the water. Also, we're going to have the electrolytes being reclaimed there, and also the vitamins are going to be absorbed there. And of course, this is where that basically all of this, the reabsorption of water, electrolytes, and vitamins, that's going to be produced by that gut bacteria. All right, the last section right here is the rectum. That's that final storage area for the solid waste or the feces, and it's stored right there before we eliminate it. So basically, it contains what we call stretch receptors that signal the body when it's time for us to pass that feces or pass that stool. All right, and then this last area right here in this picture, we have the anus, and as you can see right here, we have a sphincter muscle. All right, and the sphincter is like the bouncer that's going to allow it to open and close. We have an internal and also an external sphincter that helps control defecation, or us needing to use the bathroom. So in terms of what we see here, it is very vascular. So we have the superior mesenteric artery that does supply the cecum, also the ascending colon, and most of the transverse colon. We also have in this area the inferior mesenteric artery, and the inferior mesenteric artery, it supplies the descending colon, the sigmoid colon, and also the rectum. So venous drainage also follows a similar pattern with the blood that flows through the portal venous system, basically in order for the liver to be detoxified, or liver detoxification. So this is pretty much it in terms of the what the large intestine looks like, and also the divisions of the large intestine. All right, now here we're looking at a colorized x-ray film taken after a barium enema. Typically this would just be a black and white image, but they've added some color to it so you can further evaluate the large intestine. And again, a barium enema is a contrast study that we use in x-ray to look at the colon. We also look at the rectum and also some of the other surrounding structures. So it can help detect any abnormalities such as polyps, tumors, strictures, and also diverticuli, whether we're talking about diverticulosis or diverticulitis. So the prep for this barium enema, typically the patient is going to go on a clear liquid diet for about 24 to 48 hours before this exam, because we need them to be as clean as possible. They'll also typically take a laxative and also an enema so that they are clear of all stool within the colon. And the reason why we need them to be as clean as possible is because we don't need any fecal material to be mistaken for some type of pathology. All right, so when the patient does come in, we are going to administer barium sulfate, which is a contrast material, and it will be introduced through the rectum. So we're coming in retrograde here. If we're talking about a small bowel series, meaning looking at the upper GI, we come from above. So the patient is ingesting that barium via the mouth, but when we need to observe the lower GI tract, we come in from the rectum. So we administer the barium through the rectum. All right. Once we start the flow of the barium through the rectum, we basically turn the patient on the table in different angles. We even sometimes put the patient in a Trendelenburg type position so that we can have that barium flow upward. And of course, we need the barium to flow upward, and we also need the barium to coat all of the walls of the large intestine so that we can see it. We also give the patient air. So along with pushing in or sending in this barium, we have a tube that we attach like a bulb to, kind of like the same bulb that you would see on your blood pressure cuff, but this one is placed on the tip of the barium tube so that we can push in air to extend or descend all of these bowel loops so that we can better see all of the loops of the colon. And again, we're going to position the patient in different positions and take different images of the different parts of the colon. So there are positions that we will place the patient in to see more of the cecum area. Then we will turn them so that we can see more of the transverse colon, then the descending colon, the sigmoid colon, and also the rectum. And once the procedure is over, once the radiologist is done with their exams, we can do this live via fluoroscopy. And once they're done, we can also do what we call static images, basically x-rays in different positions so that we can see these structures better. And then once we do all of our still imaging or static imaging, we then kind of drain all of this barium back out into the bag. Then we deflate the balloon, because we do, once we do tip this patient, we do place or inflate a balloon to keep the tip in place inside of the rectum. Once we're done draining, we will deflate the balloon, remove the tip. We will send the patient to the restroom to evacuate more of the barium and also some of that air that they have in the colon. And then of course we'll come and do a post-evac image of the patient as well. So some of the things that we're looking for with the barium enema, we of course are looking for things like strictures, polyps. We can also see masses that might need to be further evaluated with additional colon type screenings like colonoscopy. We can look for things such as diverticulosis, or in case of not inflation, but inflammation or irritation of the diverticula, it turns into diverticulitis. So we're talking about those little pouches that have now, the little pouches that are in the colon wall that have now become inflamed. We can also look for things such as inflammatory bowel disease in patients that may have Crohn's disease or also ulcerative colitis. And we can also look at any strictures or obstructions that might have narrowed some of these areas or even blocked some of these areas that are preventing the normal movement of the patient's stool. All right, now we're moving on to the colon. And we talked about the different sections of the colon, so now we're just going to look at it on this particular slide. Again, the colon is the largest section of the large intestine, and again, it plays that role in water absorption, electrolyte balance, and also waste formation. It's divided into these four main sections, and again, these sections assist with the movement and also the processing of further processing of that digested material or that digested food. So we're going to start with the ascending colon, and it is located on the right side of the abdomen, and it goes up vertically. If you remember from the picture, it goes up vertically from the cecum up to what we call the hepatic flexure. So that's the first bend, and we call it the hepatic flexure because it is right there under the liver. All right, that's what we call the right colic flexure. All right, again, the function there is going to absorb water, prepare prepare for waste is basically what we're doing. The ileocecal valve, of course, is in this area as well. And again, we talk about how the ileocecal valve is the portion that connects from the small intestine to the large intestine. So that ileocecal valve is going to prevent that backflow of material from the coleum into the ileum, which is the last portion of the small intestine. All right, the next portion is the transverse colon. So in terms of what it looks like, we have the ascending colon. It goes upward. All right, then we hit the hepatic flexure, and then it transverses across our abdomen. All right, so this portion is the transverse colon. So this one is going upward or ascending. Ascending colon is here, and then we have the transverse colon here. It runs horizontally across the abdomen from the hepatic flexure, which would be here, to the splenic flexure, which would be the next curve right here. And we call that the left colic flexure. This is the right colic flexure, and this is the left colic flexure, also known as the splenic flexure. All right. And again, this transverse colon is positioned right above our small intestine. Of course, the small intestine would be coiled in this area. And again, this allows for further absorption of nutrients and water, also fermentation of things like fiber by our gut bacteria. All right, the next area that goes down here, and I've kind of run out of room, but this would be the descending colon. So we're going to descend or go downward on the left side of our abdomen, moving that waist down towards the sigmoid colon. All right, and we said the sigmoid colon is that S shape, and I can't draw it right here, but it's an S shape. Kind of do the best I can. That's that S-shaped segment of the colon that connects the descending colon to the rectum. So Again, this particular area, when we talk about the rectum, it serves as that storage area for our feces right before we eliminate it through the anus. All right, and again, the key points or the functional points in terms of our colon, that's where the water absorption occurs. About 90% of the water is reclaimed here from those digested contents. We have gut microbiota here also, so it contains trillions of bacteria that are going to aid in things like digestion, also vitamin production in terms of biotin and also vitamin K. What happens here in terms of peristalsis, again, that food or processed food or food that is being processed is moved through the colon through what we call peristalsis or wave-like movements. In this particular area, we have slow peristalsis, so it's going to move through the colon. We also have what we call mass movements or strong contractions that happen here a few times a day. And again, this is what is responsible for pushing and forming that feces down towards the rectum as all of that water is being reclaimed. All right, so we're reclaiming that water, making it more I guess of a formed feces, I guess, so to speak. If it doesn't form, meaning if there's too much water when we get to this area, we're going to have more so what is that term that we just talked about? When we have watery feces, we have diarrhea versus feces if that water is not reclaimed or if there's still too much water in the feces. All right, now the last little portion of the large intestine that we're going to talk about is the rectum. All right, and the rectum again is the last portion. We're also going to look at the wall of the large intestine as well. And all of this, again, we're talking about the portion that is responsible for not only waste storage, but also waste elimination and also the movement of all of that fecal matter. Additionally, when we talk about the wall of the colon or the outer wall of the colon, it does contain some features that help assist in digestion and also lubrication when we talk about the movement of the feces. So the rectum is the last 7 to 8 inches of the large intestine that does lead to the anus. So again, in terms of function, it's a temporary storage site for that feces before we eliminate it via the anus. It does contain what we call stretch receptors, and the stretch receptors basically signal our body or signal our brain or give us that urge to defecate. So need to go to the restroom in the terms of number 2 is what we call it. The anal canal and also the anus, that's the terminal inch of the rectum. So it basically forms the anal canal. And the anus is basically the last portion, which is that external opening, which waste will exit the body. So in terms of voluntary and involuntary movements, this area does have internal involuntary and also external voluntary sphincters. that will help regulate defecation. So from that picture that we saw earlier, you saw the two sphincters. The internal one was involuntary, meaning we can't control it, but the external sphincter we can control it. It's voluntary. So when we actually push that feces out or defecate. So in terms of the wall of our large intestine, it does contain intestinal mucus glands, and those mucus glands are responsible for secreting mucus. All right, and we do need mucus in order to help lubricate that feces so that it can pass through in more of a smooth fashion. All right, and it's also going to prevent things like irritation when we are trying to defecate or eliminate that waste. It also does have a muscle layer, and that muscle layer or the muscle fibers of the colon wall, they are typically unevenly distributed. As you can see right here is what it says. It's unevenly distributed, and it forms three longitudinal muscle bands. We call those tenicolae. And this basically creates what we call haustra, which is not on this slide, but haustra are pouch-like segments that give the colon a more segmented appearance or segmented look. All right, we also have serous membranes in the outer wall of the colon. Again, when we talk about serous membranes, we're talking about more so the peritoneum or the outer layer of the colon. And those serous membranes basically help reduce the friction between the friction that would come from movement between the abdominal organs and the outer layer of the colon. And again, we're talking more so about the extension of the peritoneum, so the lining that supports and protects the abdominal structures. All right, and in this area, in terms of clinical relevance, this might be an area where people might develop things such as hemorrhoids. So those are basically swollen blood vessels in that rectal or anal canal due to things like excessive straining. You also might get hemorrhoids from chronic constipation. Also pregnancy, the baby pushing down on this area, you may get hemorrhoids as well. Some people develop things such as fecal incontinence. So if we have damage to that external anal sphincter, we said that that was the voluntary sphincter, it can cause fecal incontinence. So we have a loss of bowel control. So we lose that ability to control the voluntary movement. So now it's more so not voluntary, it's involuntary because that external anal sphincter is damaged, so we don't have control of those bowel movements. So when we have that urge, we can't stop it, it just happens. Also in that area, that's a frequently you can that's a place where colon cancer develops in that rectum and also in that sigmoid colon area, and we can find that if we're screening when we're screening via colonoscopy. Also in this area we can have things like rectal prolapse, and that's where the rectum basically protrudes or comes out through the anus, and that's usually because the pelvic muscles have become weakened, so the rectus protrudes through the anus. All right, and that is pretty much it in terms of the last division of the small intestine, which is the rectum, and also the anus. All right, now this is your visual slide that gives you that detailed diagram of the rectum and also the anus, again highlighting the key structures that are involved in that waste storage, also the elimination, and also in terms of continence control. So the rectum, again, we said that that's the final section of the lower digestive tract. And it does lead to the anus, which is that external opening. Again, the rectum, that is the final section, which is here, and it does lead to the anus down here, and that's where the waste or that fecal matter is going to exit the body. So if we're looking at this particular picture, in terms of the rectum, it's about 12 to 15 centimeters long, and that's the temporary storage site for the feces before we eliminate it from the body. It does contain what we call transverse rectal folds or rectal valves that help support the stool, and also that passage of the stool into the rectal canal or the anal canal. All right, the anal canal, which is right here, that is the last 2 to 4 centimeters of the digestive tract that leads to the anus. It is lined with what we call anal columns. All right, right here you see that these are anal columns, these little lines right here, and these columns contain our arteries and also veins. Also in this area, you can see the rectal sinuses, and the rectal sinuses, they release that mucus that is going to be responsible for lubricating that stool so that we can have a smoother passage versus a rough passage. Now, in terms of the sphincters, it shows you right here the internal sphincters and also the external sphincters. So these are muscular, and they help control the urge to defecate. So the internal sphincters is an involuntary smooth muscle. So it's going to happen no matter what. It typically stays contracted to prevent leakage, and but it does relax when we need to defecate. The external sphincter is more so made of voluntary muscle or skeletal muscle. So basically, we typically, unless of course this is weakened, we typically consciously control or consciously have control over our bowel movement. So typically we can hold it until we get to a location where we can comfortably have that bowel movement. Some other muscles that we have here is the levator ani. That's basically a muscle that basically it's a pelvic floor muscle that helps support the rectum and the anus, and basically does play a role when we're talking about maintaining our continence. So if that area does become weakened, it can lead to incontinence. And of course, the key functions of our rectum and also the anus is, of course, fecal storage. So we're going to temporarily hold the stool until we're ready for that bowel movement to occur. Then, of course, when we are ready to use the bathroom, we have something called defecation reflex. So basically, the stretch receptors that we talked about earlier, these stretch receptors are in these rectal walls, and they're going to signal the brain when the rectum is full. So it basically triggers the urge for us to need to defecate, even though we can hold it. So basically, in terms of being able to hold it, we're talking about continence maintenance. So we're talking about the sphincters. So the sphincters and also this levator ani muscle that we have right here, they're going to regulate that voluntary and also sorry, and also involuntary muscle control. So when it comes to things like fecal incontinence, that's when we have a weakness or damage to this external anal sphincter, and it causes that patient to have basically a loss of bowel control. So they can no longer control their urge. So when they have to go, they have to go. And some of the things that can cause this are childbirth. Some spinal injuries can cause loss of bladder control, and also some nerve damage can cause a loss of bladder control. Also, earlier I talked about rectal prolapse. So that is when the rectum will protrude through the anus. So it will basically drop down through a weakened pelvic floor muscle. And this rectal prolapse typically is going to happen, or can happen, or does happen in more so elderly patients, and also patients that might have chronic constipation as well. All right, now we're looking at a microscopic view of the walls of the colon, and some of these terms that we've seen already. But now specifically we're talking about the walls of the colon, and of course this is a microscopic or histological view of the colon wall. So we're looking at some of those key structural features of the colon, like the lining, the epithelial lining, the glandular structures that are essential for lubrication, water absorption, and also protection against some of the harmful substances that transverse through this area. So here we're looking at the lumen of the colon, and the lumen is a hollow space where that fecal material moves through the large intestine. So it's lined with columnar epithelium, which is a specialized cell that helps with the absorption and also secretion. We also see these goblet cells again here. These are those mucus producing cells that are scattered throughout the epithelium, and also the intestinal glands as well. And the job or the function of these cells is basically to lubricate the feces so that we can have easier movement or easier bowel movements as it's transversing through. Also, it does protect the colon walls as well. So we do have a lot of mechanical stress as this feces is transversing through. So basically the lining is there for protection from irritation that might be caused by the waste as it's transversing through. All right, another thing that's listed here is the intestinal crypts, or the lips of Lieberken again, and these are these straight tube-like glands that extend deep down into that mucosal layer, and it contains those stem cells that help regenerate that epithelium, ensuring that we have a continuous cell turnover in that area. Last but not least, down here we can see the muscularis mucosa and also the submucosa. So the muscularis mucosa, that's a thin layer of smooth muscle that's going to aid in basically the movement of that mucosal layer, And we also have the submucosa, and that's the area that's going to contain the blood vessels, the lymphatics, and also the nerves that are going to support and aid in nutrient absorption and also our immune function. And again, the functions of this colon wall, again, it needs or it assists with the water and electrolyte absorption. So basically, that epithelium is going to reclaim or reabsorb water and also minerals to prevent dehydration. Also, it assists or aids in mucus secretion. Again, those goblet cells are going to produce mucus in order to facilitate a smooth passage of the stool. So it's going to prevent irritation as that stool is being passed. And it also helps in terms of barrier functions. The colon wall acts like a protective barrier against harmful bacteria and also toxins that are within the area. All right, now we're going to talk about the appendix, also called the veriform appendix. All right, and the appendix is a small tube-like structure. I don't know if you paid attention on the previous slide, but it's very small and it's located at the junction of the small and the large intestine. So again, typically we thought that it didn't really have a function, but we did now studies show that it does play a huge role in gut immunity and also in microbiome balance. So the balance of the bacteria within our gut. So in terms of the anatomy and the function of the appendix, it measures about 8 to 10 centimeters in length. It's connected to the cecum, which is the first part of the large intestine. And in terms of function in the digestive system, it's a reservoir for bacteria, specifically the beneficial gut bacteria. So again, it does play a role in immune system function. In terms of the role that it plays in the intestinal microbiome, the appendix does help us maintain a healthy bacterial population within our gut. So when we talk about the gut flora, if it's disrupted by things like antibiotics or some type of infection, the bacteria, we have healthy bacteria or good bacteria that is stored in the appendix that can repopulate or move to the colon to help restore the healthy balance that it needs. So again, the function that it has is critical when we talk about preventing pathogenic bacteria from becoming dominant within our gut. So again, it helps restore the healthy gut. In terms of clinical significance, when we talk about the appendix, this is the area where the person might have appendicitis. So appendicitis is when we talk about the term itis, that is inflammation of the appendix, typically due to some sort of infection, or it can happen due to some sort of obstruction as well. So the patient might present with severe right lower quadrant pain, and of course that's because the appendix is located in the right lower quadrant. They might be nauseated or vomit or present with vomiting, and they also might have a fever as well. Treatment for appendicitis, typically that person needs for their appendix to be surgically removed via an appendectomy, especially if the appendix has ruptured. But we do typically, hopefully, can get to it before it ruptured. The appendix in terms of gut health, again, research does show that people that don't have their appendix, they do have or are more prone to things like recurrent gut infections, and microbiome imbalances. So again, the appendix does help with things like digestion and also storing that healthy gut bacteria. All right, now we are going to move to the peritoneum. All right, and the peritoneum is basically a large, what we call continuous serous membrane. So it basically lines our abdominal pelvic cavity, the entire cavity, and it covers a lot of the organs that are housed there. So it does play a role in terms of organ support and also lubrication and also structural organization within our abdominal cavity. So some of the key components of our peritoneum are the visceral peritoneum, and the visceral peritoneum basically covers the surfaces of our abdominal organs like our stomach, also the intestines, and also the liver. And it also provides protection and also lubrication in terms of reducing friction whenever we have movement in that area. All right, another part of the peritoneum that we have is the parietal peritoneum. And the parietal peritoneum basically lines the inner wall of the abdominal pelvic cavity, and it also helps anchor those organs and separate them from the extra peritoneal spaces. We also have in the peritoneum, we have the mesentery, and the mesentery is a double layer of peritoneum that helps suspend our intestines from what we call the posterior abdominal wall. And this mesentery area does contain blood vessels. It also contains lymphatics and also nerves that support and supply the intestines. So in terms of function, this mesentery area does allow for free movement of the intestinal loops, and it also prevents things like volvus, which is basically a twisting of our intestines. And this is a condition, volvus is a condition that we can see in some of our radiographic imaging procedures. All right, and then last but not least for this slide, it talks about the transverse mesocolon. So this is an extension of the peritoneum that helps support that transverse colon, and it helps maintain the positioning and also the function of the colon. So again, we're talking about, when we talk about the peritoneum, we can talk about it in terms of extraperitoneal and also retroperitoneal spaces. So extraperitoneal spaces are located outside of the parietal peritoneum, things like the kidneys, the adrenal glands, and also the ureters. And then retroperitoneal space, things that are retroperitoneal, they are posterior to, or the posterior portion of the extraperitoneal space. So we're talking about along the back of the abdominal pelvic cavity, and some of those organs that are contained in that area are things like our kidneys, the pancreas, and also some parts of the duodenum or the duodenum also there. So in terms of clinical relevance, when we talk about the peritoneum, things that can occur there are things like peritonitis. So basically inflammation in the peritoneum typically are going to be due to things like infection. Also something that can cause peritonitis is a ruptured an abdominal organ like an appendix. Symptoms of peritonitis are going to be severe abdominal pain, again, fever, nausea, and also we might have some rigidity in the abdominal area. Ascites can happen in this area as well. So we have abnormal fluid buildup in the peritoneal cavity. Typically, ascites is due to liver disease like cirrhosis or some other type infection. Also in this area, we can have volvus. I said earlier, in terms of volvus, we have that intestinal twisting. For this one, we would need to have some type of imaging, specifically radiologic imaging. We can see that there. So basically, if the mesentery area fails to support the intestinal loops properly, some of the sections of the intestine can twist. And if we do have that twisting to occur, it can cause an obstruction, which wouldn't be good. And some of the this is somewhat common in areas like our small intestine, and also the sigmoid colon can have this volvus occur. Also in this area, we can have things like a retroperitoneal hemorrhage. So with this one, we're talking about bleeding into the retroperitoneal space, which can result from things like trauma. You can also have a ruptured aneurysm in this area, or some pancreatic conditions could happen that can cause this retroperitoneal hemorrhage. This one, a hemorrhage in this area is typically difficult to detect if we're talking about a physical exam. So typically, if there's some type of hemorrhage in this area, the patient may need a CT exam. So again, this is a radiologic exam. So again, the peritoneum does provide support and organization for our abdominal cavity. The mesentery and also the peritoneal extensions are going to allow for free movement of the intestines, while it does prevent things or complications like the volvus or the twisting. And then also just understanding some of those peritoneal spaces that we talked about, retroperitoneal versus extraperitoneal, is going to help you better be able to diagnose or maybe indicate conditions like peritonitis, ascites, and also retroperitoneal hemorrhage. All right, now we are looking at the peritoneum and its reflection. So this is a sagittal, I'll say a sagittal view, or a side view, or a side slice of the abdomen. And we're basically looking at the peritoneum and what we call the reflection. So again, the peritoneum is basically that continuous serous membrane that is going to align the abdominal pelvic cavity. So we're talking about the abdominal area and also the pelvic area. All right, and that's where all of the abdominal organs are contained. So it basically encloses and protects all of these organs. So this particular diagram shows us the different portions in terms of intraperitoneal. Those are going to be the yellow spaces, and then extraperitoneal are going to be the green spaces. So retroperitoneal, also we're going to talk about that as well. So retroperitoneal space, that's the part of the extraperitoneal space that's located along the posterior abdominal wall. So again, these are some of the key peritoneal structures that we're going to look at, as well as the role, or kind of talk about. So again, in terms of the yellow colors, or the intraperitoneal space, As you can see, it contains some of the organs that are completely or mostly enclosed by what we call visceral peritoneum. So things like our stomach, our liver, our spleen, stomach, liver, um, our spleen, and also most of our intestines are in this intraperitoneal space. As you can see, they're all lying within the yellow. And again, this intraperitoneal space, not only does it provide mobility, it also provides protection, and also lubrication is going to allow those organs to move freely during digestion. All right, in terms of extraperitoneal, now we're talking about the green locations within the diagram. These are things that are located outside of the peritoneal cavity. So outside, and when we say outside, they can be located anteriorly in front of, or they can be located posteriorly, meaning behind, or behind, or in the back. So some of these areas includes the subdivisions like the retroperitoneal space and the preperitoneal space. So the retroperitoneal space, or the posterior extraperitoneal region, contains organs that are only partially covered by the peritoneum, and also positioned behind the peritoneal cavity. So some of the things that we see in this area are the kidneys. We also see the adrenal glands in these areas. The pancreas is also located in this area. The duodenum is also in this area. Let's see, the ascending and the descending colon are also located in this area. And then also we have the abdominal aorta, and also the inferior vena cava is also located in this area. So in terms of clinical importance, the organs here are a little bit less mobile and more protected than the intraperitoneal organs. So in terms of things like retroperitoneal hemorrhage, meaning bleeding behind the space, if we did have this, it could be life-threatening. It also could be very difficult to diagnose. So we would have to have some type of imaging like CT to diagnose something like that. And again, we talked about things in terms of clinical significance. We talked about things like peritonitis, retroperitoneal hemorrhage as well. There's also something called abdominal compartment syndrome. So if a person had abdominal compartment syndrome, we're talking about increased pressure within this peritoneal cavity, and it can cause our organs to typically dysfunction. This pressure might be more so seen in patients that are ill, meaning critically ill. And in terms of treatment to get this pressure off of the peritoneal cavity, we would need to surgically decompress compress it. So of course the surgery might be necessary. Also, in terms of things that could happen in this peritoneal area, a person might receive peritoneal dialysis in this area. So basically, we're talking about treatment for kidney failure. So the patient would have their blood being filtered through the peritoneal membrane. So again, this is a treatment that could happen in this area. So again, this peritoneum we're talking about is going to support those vital organs. It's going to protect those vital organs, and it also organizes the organs that are within our abdominal cavity. So now we're taking a look at the abdominal viscera and also the peritoneum. So we're looking at an anterior view or front view of the abdominal viscera, and it shows us some of those peritoneal structures. It shows us the flexures. It shows us, of course, the colon and also the small loops of the intestine. Also, in this particular image, our book does say that it does have the transverse colon and also the greater omentum elevated. Typically, these are going to be lower. And we're elevating them in this particular image so that we can see some of these underlying structures. So some of the key structures that this particular image highlights in terms of the peritoneum and its reflections, we can see the peritoneum here. And again, the peritoneum, that's that membrane that covers and supports the abdominal organs. All right, the greater omentum, which is located here, that's a large fatty peritoneal fold. Typically, it's going to drape over the intestines and it's going to act more so as protection and also insulation for our organs. All right, we can see the colon here. Colon, typically we're talking about the large intestine. We can see the colon and its flexures. Again, we said that this is elevated. Typically, this would go up, meaning the ascending colon, and then the transverse colon would drape this way across. So let me see if I can draw on this. We would go up via the ascending colon, and then the transverse colon, once it hit the hepatic flexure, would drape across to the splenic flexure, and then of course we would drop down to the descending colon, down into the sigmoid colon. All right, so the colon and the flexures, the hepatic flexure is located here on the right side, and of course this is a little bit odd because we have this transverse colon elevated, and it's located where that ascending colon, which is this part that ascends or goes upward, it transitions from the ascending colon to the transverse colon, and it's positioned near the liver. That's why we call it the hepatic flexure right here. All right, once it transverses over laterally or drapes laterally, it does hit the splenic flexure, which is the left colic flexure. And the left colic flexure marks the transition between the transverse colon and the descending colon. So we're going to descend or go downward via the descending colon. All right, the left colic flexure is also called the splenic flexure as well because it is located near the spleen. So that's why it has that name. And this one has the hepatic flexure because it's located near the liver. So the flexures basically allow the colon to kind of fit within the abdominal cavity in terms of structure, and it also helps aid in the movement of the waste. Also here in this particular image, we can see the loops of the small intestine here. We can see the jejunum, and we can also see the ileum. And of course, they are suspended by the mesentery, which allows for movement, but it does prevent it from twisting. And again, the clinical term for twisting, we called it volvus, which we diagnose in x-ray. Now, as you can see, the small intestine is folded into loops, and those loops, of course, it allows for more so, it allows us to maximize the nutrient absorption that occurs right there in the small intestine. All right, because again, we said that small intestine is where most of the nutrients is going to be absorbed. All right, we can also see here the cecum. That is the first, well, the cecum and also the appendix, which we can't really see, but it's a little projection off of the cecum. And again, that is the first portion of the large intestine, or the first portion of the colon. And that's where the ileum, which is the last portion of the small intestine, connects. And it connects via the ileocecal valve. All right, so the valve that connects the ileum and the cecum. All right, the appendix, or the variform appendix, again, we used to think that it did not really have a purpose, but studies have shown that it does help hold that healthy bacteria, so it helps with gut microbiome regulation, keeps us or helps us maintain a healthy gut. So in terms of functions of these structures, if we go back up here to the greater omentum, again, it acts the greater omentum, as you can see, it acts for, or as, an area for fat storage. It also helps with our immune response, and it is also an infection barrier as well. In terms of the peritoneal reflections, the mesentery and also the omentum, they're going to provide us with vascular support and also flexibility in terms of the digestive organs. We also see again those flexures, and the flexures basically help aid in the transport of that waste, and it also prevents excessive looping of the colon. So we don't want to have excessive looping of the colon like that we have down here in the small intestine. So it allows for that smooth transport and transport of that material, or that waste material. All right. In terms of clinical relevance, what we could have in this area, we could have things such as omental inflammation, or omentitis, which is an infection that can happen due to infection, due to it can happen also if we have some sort of trauma, and also it can happen after surgery, so some sort of post-surgical complications. Also, we talked about volvus, which could happen in the bowel, which is bowel twisting. Typically, volvus occurs, it can happen in the colon, but it can happen in the small intestine as well. So basically, these loops twist on themselves, and it can lead to a bowel obstruction. Also, within the colon, we can have things like diverticulitis, which is inflammation of diverticuli, which are pouches that are in the colon. Often, this diverticulitis is going to occur near these flexure areas or near the sigmoid colon. Also, within this abdominal viscera, we can have appendicitis, and that's inflammation of the appendix. And again, typically if we're having inflammation there, we do want to catch it before it ruptures, so they might perform a surgical removal of the appendix. Appendectomy is what would happen here. So this is basically, we're just looking at how the abdominal organs would be arranged within the peritoneal folds, or as well as the mesentery and also the omentum. So on this slide, we're now looking at another projection. And for this one, we're looking more so just at the transverse colon and also the greater omentum. So we're showing the transverse colon here. Of course, it is lifted a little bit. We have the greater omentum here. Again, lifted a little bit. We also have the mesocolon here and also the mesentery as well. So here we're looking at this transverse colon and the omentum. Again, we have it raised. And we also, if you've noticed, we've pulled the small intestine kind of to the side so that we can expose the peritoneal structures that are underneath. So some of the structures that we're looking at here or highlighting here is the greater omentum. Again, this is that fatty apron fold of the peritoneum. Again, it's typically going to drape over the intestine, and it's going to provide it with, in terms of functionality, it protects and it also insulates our abdominal organs. We also said earlier that it does contain some immune cells, and those cells are going to help fight infections. And it also acts as fat storage. As you can see, all of this fat, and that fat is stored there not only for cushioning but also for energy. All right, we can see the transverse colon here as well. So this is the middle section of our large intestine, and it extends from the hepatic flexure, which would be this first turn right here, the right flexure, and also the splenic flexure. So it extends from the hepatic flexure, which would turn here, over here to the splenic flexure. And it's not pointed out. The flexures aren't pointed out here, but we should know that we go up, we ascend, then we have that first flexure here, which is the hepatic flexure, which makes this turn, and then we transverse across and hit this splenic flexure, and then we descend. All right, so we're looking at also the transverse mesocolon, which is right here, and that supports basically this section, and it allows for some mobility in this area. So in terms of the transverse mesocolon, it is a layer of the peritoneal, and it connects this transverse colon to the posterior abdominal wall. That's the job. So it basically, in terms of function, it does provide vascular support. So it contains blood vessels, nerves, and also lymphatics. And it allows the transverse colon to move, but it doesn't allow like excessive movement or excessive displacement. Also, in terms of the mesentery, which you see here, it supports the small intestine that we have pushed aside here. So this one is another fold in the peritoneum, and it anchors the small intestine to the posterior abdominal wall. And just like the mesocolon, this particular mesentery allows for that blood flow and also the nerve supply to our intestine. It allows for free movement of the loops, but of course not allowing those loops to twist. So we're talking about, if it's twisting, we're talking about the volvus, which would obstruct our intestines. So again, in terms of functional significance here, the greater omentum and also the mesocolon, they provide organ stability and also suspension. It provides fat storage and also immune response. And it does prevent things such as peritoneal adhesion. So it reduces the friction between these abdominal cavities or abdominal organs. Now we're going to talk about the liver. And the liver is considered to be the largest gland in the body. So not the largest organ, but the largest gland in the body. It weighs about 3 to 4 pounds, which is 1.5 kilograms, and it's located in the right hypochondrium part of the epigastrium, so just beneath the diaphragm. The liver is needed not only for detoxification, but also for metabolism, and it's also needed for digestion. So in terms of the lobes and also structures of the liver, this particular slide talks about the different lobes of the liver. So the liver is divided into two major lobes and is separated by what we call a falciform ligament. So the right lobe, which is the larger of the lobes, forms about 5/6 of the liver, so the majority of the liver. And the left lobe, which is the smaller portion or smaller lobe of the liver, forms about 1/6 of the liver. The right lobe is further divided into what we call a caudate lobe near the inferior vena cava, and also the quadrate lobe, which is near the gallbladder. We also have hepatic lobules. So these are the functional units of the liver. So the liver basically has these hepatic lobules, and they're functional units. So they're microscopic. And each of these lobules contains what we call hepatocytes. So these are liver cells. All right, and they're arranged in what we call plates. In terms of the lobules, they also contain a central vein where a branch of the hepatic vein extends through the center, and we also have in this hepatic lobule a portal triad, and basically these are hepatic. This is a hepatic artery, a portal vein, and also a bile duct. And this is at each lobule corner. So in terms of function, the liver, we said that it assisted with metabolism and also storage. So it does regulate blood glucose, and it does this by storing excess sugar, and it stores it in the form of glycogen. It also, the liver also processes amino acids and converts excess nitrogen into a substance called urea, which we need to excrete. It also stores vitamins and also minerals, and these include vitamins such as vitamin A, vitamin D, B12, iron, and also copper. Another function that we said that the liver has is it aids us in detoxification and also blood filtration. So it breaks down toxins, especially things like drugs and also alcohol. And this can be legal drugs, meaning we're prescribed or maybe over the counter, but also those illegal drugs as well. And of course, alcohol. And it breaks them down so that they can be excreted by the kidneys or bowel. And it also removes old red blood cells, producing what we call bilirubin, which is a byproduct that is excreted in our bowel. In terms of another function that it has, it does assist with bowel production and also digestion. So it produces bile, which helps or aids in digestion, specifically the absorption of the fats. So bile itself is stored in the gallbladder, which we will talk about the gallbladder as well. So it's typically stored in the gallbladder before it's released into the small intestines. And it also, in terms of liver function, we have protein synthesis that happens here as well. So it produces albumin, which we did talk about in our labs this week. And the albumin helps maintain our blood pressure, and also it helps with our clotting factors as well. Clotting factors aid with blood coagulation. So some things in terms of clinical relevance that could happen with our liver is liver cirrhosis. So that's a chronic liver disease leading to what we call scar tissue formation. And if we have that scar tissue formation, it could eventually impair the liver function. Also, some of the common causes of liver cirrhosis are alcoholism. The patient could have hepatitis, and also we can have fatty liver disease. So in terms of fatty liver disease, basically patients that are obese can have fatty liver disease, which could lead to liver cirrhosis. Also, we can have jaundice. All right, and jaundice is basically a yellowing of our skin and also the eyes due to bilirubin buildup. So often from liver disease or some type of bowel duct obstruction. Also, we can have hepatitis. So hepatitis is a viral infection. We have hepatitis A, hepatitis B, and also hepatitis C, and it causes liver inflammation and also liver dysfunction. And last but not least, in terms of liver, we could have liver failure that would lead to us needing to have a liver transplant. So end-stage liver disease may require us to have a liver transplant. So the liver is definitely a vital organ. It has a ton of functions. In terms of functions, these are essential functions like metabolism, detoxification, protein synthesis, and also digestion. In terms of these hepatic lobules, they're basically functional units of the liver, and they facilitate blood filtration and also bowel production. In this picture, we are looking at a normal liver. This particular liver is being prepared for an organ transplant, so a person who needs for their liver to be basically replaced. Again, we said that the liver is the largest gland that we have. Is responsible for metabolism, detoxification, digestion, and also blood filtration. If a person is having a liver transplant or liver transplantation, they basically need it as a life-saving procedure. So patients that have end-stage liver disease or acute liver failure, they would need for their liver to be replaced. So have a liver transplantation. Again, in terms of the liver functions, in terms of size, and also in terms of weight, the liver weighs about 3 to 4 pounds, about 1 to 5 kilograms. This is in an adult. As you can see right here from this picture, well, of course we can't feel it, but it is soft, and it's usually a reddish brown color. It is highly vascular, meaning there's a lot of blood vessels and veins there. We can see the different lobes here. So it has the 2 lobes. For this image, the right lobe, which is the larger lobe, it's about 5/6 of the liver's mass, and the left lobe, which is the smaller lobe, is about 1/6 of the liver's mass. And we do have additional subdivisions, but we can't really see them here. We have the caudate and the quadrate lobes that we talked about earlier. In terms of hepatic vasculature, the liver receives most of its blood supply from the hepatic artery and also the portal vein. So the hepatic artery, we're talking about that oxygenated blood from the aorta, and the portal vein, we're talking about nutrient-rich blood from the intestine. So again, it has a dual blood supply, and blood basically drains through the hepatic veins into our inferior vena cava. In terms of bowel production and also the duct system, of course, the liver does produce bile, which eventually is going to be stored in the gallbladder before it is eventually released into the small intestines to assist with digestion. All right, and in terms of bowel production, and again, duct system, the liver does have the common hepatic duct, and it basically transports that bowel towards the duodenum, or the duodenum. All right, in this slide we are looking at two views or two perspectives of the liver in terms of the anatomy. This B image is the anterior view or the front view of the liver, and this C image is an inferior view or the underside of the liver. So some of the structures that are not visible from the front, we can see it in the inferior view. All right, so in terms of what we're looking at right here in the anterior view, we can clearly see the right and the left lobes. All right, the right lobe, as you can see, is significantly larger than the left lobe, and in the center we can see the falciform ligament. So that is a ligament that divides the liver into the two lobes, and it also anchors the liver to the anterior abdominal wall as well. As you can see from the visual of the liver, it is smooth. It does have a convex shape. So in terms of the curvature here, when we're looking at it, it does kind of follow the contour of the diaphragm, mainly because the liver does sit, the diaphragm in terms of contour, it does sit underneath the diaphragm. In terms of location, we talked about the gallbladder, but the gallbladder is here. You cannot really see it from this interior view because it's partially hidden, but it is tucked underneath the right lobe, and we'll be able to better, we are able to better see it in this inferior view. So when we look at this inferior view over here, we do see some additional structures that we couldn't see from this front anterior view. So what we did see that was kind of hidden, but it was kind of projecting underneath, is the gallbladder. We can clearly see it right here in this inferior view. And the gallbladder, again, is located in the underside of the liver, specifically the right lobe of the liver, and that's where that bowel is going to be stored until it's released. We can also see the inferior vena cava. We could somewhat see it in the interior view, but now we can see it better with the inferior view. And it passes posteriorly, of course, collecting that deoxygenated blood from the liver. All right, also in this particular view, we can see, let's see, the hepatic portal system connections here. So we see the hepatic portal vein here. We can see the hepatic artery here. So the hepatic portal system, these are basically the portal veins that are going to bring that nutrient-rich blood from the intestines for processing, and of course the hepatic artery is going to supply the liver with the oxygenated blood. All right, also we can see the quadrate lobe and also the caudate lobe as well. So these are the lobes of the right. These are the additional, I'll say, divisions of the right lobe of the liver. The caudate lobe, quadrate lobe is located near the gallbladder, as you can see, and the caudate lobe is located near the inferior vena cava, which we talked about that in an earlier slide. And last but not least, we can see the liver hilum or the porta hepatis, and this is the entry and exit point for the hepatic artery and also the portal vein and also those bile ducts. So again, this is the porta hepatis. All right, and that is pretty much it for this slide. Again, this is the interior view that highlights the lobes and the overall shape of the liver. And then of course we're looking at the inferior view as well, which gives us a little bit more details of structures that are hidden that we can't see from the anterior view. In this slide, we're looking at the liver lobules and kind of a circulatory scheme here. So we're looking at the liver circulatory system. So in terms of the liver lobules, so it's showing you one here. These are those functional units of the liver that we talked about earlier. They're kind of arranged in a hexagonal pattern. And again, in terms of the circulatory scheme, we're talking about how blood enters, circulates, and also exits the liver, as well as how bile is going to be transported. So again, we're looking at this small liver lobule. Again, it's a hexagonal structure, and it's composed of what we call hepatocytes or liver cells. Each lobule is surrounded by branches of the portal triad. And when we talk about the portal triad has a hepatic artery, it has a portal vein, and it also has a bile duct. So basically, with this, blood is going to flow through what we call sinusoids, and we talked about those earlier, but these are basically capillary-like spaces before they reach a central vein. In terms of the hepatic circulatory system, we have in blue, we have the hepatic portal vein. All right. And this basically carries nutrient-rich blood from the digestive organs to the liver for processing. We have the hepatic artery, which is in red, and it supplies oxygenated blood to the liver from the aorta. And then we also see the inferior vena cava here, as well as some of the hepatic veins. And so once our blood is filtered, it drains into more central veins, which will merge into hepatic veins before they exit via this inferior vena cava. So in terms of biliary transport or the movement of bowel, the hepatocytes that we talked about will basically produce bowel. So while it's secreted into what we call a bowel canal, like a bowel canal. So the bowel is then going to move into the common bile duct, which is located right here. And after it moves there, it's going to either flow into the gallbladder where it will be stored. As you can see right here, common bile duct allows access to the gallbladder, or it can pass directly into our small intestine via the duodenum or the duodenum, and it's going to help assist in digestion at that point. So again, this basically gives us a visual and kind of attempts to illustrate how blood is going to enter the liver, how things are going to get processed, specifically the blood in the lobules, and also how it's going to exit through those hepatic veins. So basically it's highlighting the biliary system as well, showing basically how the movement of bowel occurs from the liver to either the gallbladder or to the intestines. So again, this is just a visual. And again, the job of the liver, it processes nutrients, it detoxifies the blood, and also it produces bile. Now in this diagram, we're looking at blood flow in the liver lobules. So this is like a microscopic view of those lobules that we talked about. So it tries to show us the direction of the blood flow and also how bowel moves. So again, highlighting how blood flows from the hepatic portal vein and the hepatic arteries, entering the liver, circulating through those lobules, and then exiting via that central vein. Also, is trying to show us how bowel not only is produced by those hepatocytes, but also how it drains into the bile duct. So again, this is somewhat of I'll say a busy slide. So if we're looking at, so we have two diagrams. We have diagram B, and we also have diagram C. So if we're, if we're looking at in terms of blood flow in the liver, and also when we're specifically talking about the hepatic portal vein and also the hepatic artery, we're specifically looking at basically the black arrows of how it flows. So this first image right here, we're looking at how the blood flows, and in this bottom image down here, we're going to be not only kind of looking at how blood flows, but also how the bowel flows. So if we're looking at this first image, the first thing we want to look at is the hepatic portal vein and also the hepatic artery. So here we have the hepatic portal vein here, and this is very tiny, but we should also be able to see the hepatic artery. Don't really see it here. But this red signals the hepatic artery, but we do see the hepatic artery down here in image C. So the hepatic portal vein, we already know that it carries what we call nutrient-rich deoxygenated blood from the intestines. And the hepatic artery is going to supply oxygenated blood from the aorta. So when we're looking at this particular image, those are some of the things that we're interested in. Also, in terms of the image, we're going to look at, we discussed the sinusoids and also the hepatocytes earlier. So blood from both sources are going to flow into the sinusoids, which are those capillary-like vessels that are located in the lobules. In terms of the hepatocytes, these are the liver cells. They're going to process nutrients. They're going to remove toxins. They're also going to help with metabolizing some of those substances. And in terms of some of the central veins, which we see here, and also the hepatic veins, they basically are, after filtration occurs, blood is going to flow towards these central veins at the center of each of these lobules. So the central veins basically will then merge into the hepatic veins. So you can see the central veins here. They are merging into the hepatic vein, as you can see, central veins merging into the hepatic vein, and of course they will basically empty into the inferior vena cava. So in terms of bowel flow, we're now looking at the yellow arrows. So blood flow was basically the black arrows. Bowel flow, we're looking at the yellow arrows. So again, bowel flow in the liver. Of course, we know that bowel is produced by those hepatocytes. They're going to produce the bowel, and of course we need the bowel in order to digest fats. Bowel ducts are then, in terms of bowel flow, it's going to flow through these small channels called bowel canaliculi, which I don't really see on this particular slide. However, just note that they will flow through those channels, and they're going to flow towards our bowel ducts. The bowel ducts will eventually lead to the gallbladder. So again, the liver that is produced, the bowel that is produced by the liver will either be stored in the gallbladder, or it can directly move into the small intestine, where it can assist in digestion. So again, the key takeaways from this diagram, and this is really small, so you may need to look at your book to kind of follow the black arrows and also the yellow arrows. In terms of blood and bowel flow, they flow in opposite directions in the lobules. As you can see, the blood flows this way and the bowel flows this way. The liver is going to simultaneously filter the blood and also produce bowel, and of course that basically tells us or shows us that the liver has a dual role in terms of the circulatory system and also in terms of our digestive system. In terms of the sinusoids that we talked about earlier, and you can't really see them in this particular image, but in terms of what they allow is the sinusoids allow for efficient exchange of not only nutrients but also oxygen and waste removal between the blood and those hepatocytes. So again, this diagram, we're just looking at the circulatory system at work, and we're also looking at bowel production at work as they're working side by side in order for us to maintain that balance that we need. In this slide, we're looking at, again, a cross-section of a hepatic lobule. So we're looking at a histological cross-section, meaning something that we're looking at under the microscope. So this is a microscopic view of some of the architecture of the liver. So in terms of the hepatic lobule, again, that's that functional unit of the liver. It's responsible for that blood filtration, the metabolism, and also the bowel production. So some of the things that this particular slide is showing us, the first thing it shows us is the central vein. All right, and the central vein is basically the middle of the lobule. So it collects filtered blood from those sinusoids. It drains into the hepatic veins, which carry that blood on into the inferior vena cava. Now, it also shows us the sinusoids as well. So these are those capillary-like spaces that allow blood to flow from that interlobular portal vein towards the central veins that we saw in that previous image. They also basically facilitate the exchange of nutrients, oxygen, and also waste between those hepatocytes in our blood. Also, in this particular image, we see the interlobular portal veins, all right, along the periphery of the lobule. And again, this is part of that portal triad that we talked about, supplying that nutrient-rich blood from those digestive organs. So basically, blood is going to enter the lobule through these portal veins, passing before it passes through those sinusoids. The other thing that we see here is the hepatocytes. So these are the liver cells, and again, they're typically said to be arranged in what we call plates between these sinusoids, and they form what we call granular epithelium in the liver. And the primary role of these hepatocytes, basically, we're going to be metabolizing the nutrients, we're going to be detoxifying substances, and we're also going to be producing bile. That's what these cells are responsible for. So in terms of the flow of blood through the lobules, and we tried to look at this in this previous slide, but blood is going to flow from the interlobular portal veins. It's going to enter the lobule. It will travel eventually through these sinusoids where the hepatocytes will process those nutrients and also remove the toxins. In terms of filtered blood, it will then drain into this central vein and eventually exit through the hepatic vein. So again, this is what we call systematic circulation in terms of the liver. So that is pretty much it from this slide. We're just looking at a microscopic view of the lobule. All right, now we're going to talk a little bit about the bile ducts, and we're going to talk about some imaging techniques that your book talks about. So we already learned that the bile duct system is responsible for transporting that bile from our liver to the small intestines to assist with digestion. So one of the things that we're going to introduce here, we're going to talk a little bit about endoscopic cholangiography, which is a procedure that we use in order to visualize not only the biliary ducts, but we can also look at the pancreatic ducts as well. So in terms of structure and also the flow of bile, we have the hepatic ducts. All right, so in terms of the formation of those hepatic ducts, we first have the small bile ducts that are in the liver, and they merge to form what we call the right hepatic duct, which drains the right lobe, and also the left hepatic duct, which drains the left lobe. The ducts do immediately join to form what we call the common hepatic duct, which we did look at on a previous slide. And the common hepatic duct, in terms of its formation and function, again, the hepatic duct merges with what we call a cystic duct from the gallbladder to form the common bile duct. And the common bile duct is going to transport that bile into the duodenum and aid with digestion. So again, we know that the bowel can move to straight into the intestine to help with digestion, or it can be stored. Um, so again, in terms of imaging, biliary imaging that your book talks about, it talks about endoscopic cholangiography. So this is a procedure that uses X-ray, and also sometimes we are using a scope as well, but we're able to visualize the bile ducts in the gallbladder to help diagnose things like gallstones. We can look for strictures, we can look for tumors, and we can also look for bowel obstructions as well. So um, in this cholangiography, what we do is we put a flexible endoscope, or insert a flexible endoscope through the patient's mouth, down the esophagus, and then into the stomach, which eventually will transverse into the duodenum. We also will have a small catheter that we have introduced into the ampulla of Vater, which is one of the major duodenal papillas. Um, with that, we're going to inject a contrast media into those bile ducts. So a contrast media is basically something that's going to highlight um, the bile duct within that image, because typically we're not able to see it, but when we inject that contrast media, just like when we saw on the um, colon imaging, when we saw the contrast, the white areas, for this one we're injecting a contrast media as well. It's not barium, but it is a contrast media that will highlight this and make the ducts visible on the x-ray. So if necessary during this procedure, we are able to remove things such as stones. If there's some type of stricture or blockage, we are able to place stents to keep those ducts open. And some of the other things that we can do with this procedure is we can also use it to fill the pancreatic duct for imaging, to visualize pancreatic disorders. So again, in terms of the bile duct and its role in digestion, it basically will direct the bile either from the liver to the gallbladder to be stored, or from the liver to the intestine to aid with digestion. It can also go from the gallbladder to the intestine to assist with digestion. Now we're going to talk about the functions of the liver, which we have been talking about for a while, but we said that it assists with detoxification, metabolism, bowel secretion, and also protein synthesis. So some of the key functions that we're going to talk about in terms of detoxification, the liver cells, which we call hepatocytes, they neutralize toxic substances that enter our body through either ingestion, metabolism, or circulation. So it basically converts harmful substances into what we call non-toxic metabolites, which are then excreted via the kidneys, via the urine, or via the bowel in feces. In terms of bowel secretion, which is the next bullet point here, the liver does secrete approximately 1 pint of bowel per day. And again, bowel assists us with the digestion and absorption of fats. Bowel salts, we also have that are essential, and they're derived from cholesterol. They're essential for emulsifying fats and also helping to facilitate with fat or lipid breakdown within our intestines. All right, in terms of liver metabolism, Again, it plays a major role in our metabolism, meaning it's processing and storing nutrients for us. In terms of proteins, it converts amino acids into glucose, and it also removes nitrogen as urea. In terms of fats, it regulates fat metabolism and also cholesterol synthesis. And in terms of carbohydrates, it stores glucose as glycogen, and it also removes it when it's needed for energy. All right, the last bullet point here, production of plasma proteins. The liver does also synthesize blood proteins, specifically albumin, which helps maintain our blood pressure and our fluid balance, and also some of the clotting factors that are essential for us to be able to have or form blood clots, so things that are essential for blood coagulation. All right, in terms of storage, again, essential nutrients are also stored as well. Now we're moving on to the gallbladder anatomy. So in terms of the shape of the gallbladder, it appears or is said to be a pear-shaped organ. Again, the gallbladder is responsible for storing and also concentrating bile before it's released into our small intestine. So in terms of the structure, location, and also layers, as well as the capacity of bowel storage, that's what we're going to talk about in this particular slide. So again, anatomy, in terms of size and shape, it measures about 7 to 10 centimeters in length, and it's about 3 centimeters wide at what we call the broadest point or the widest point. It is a hollow muscular sac, and it can expand and it can contract as needed. In terms of the location, we saw that earlier. It is on the undersurface of our liver in a shallow depression. So if we're looking at the liver from an anterior view, we can only see like the bottom portion of it, but if we flip the liver over to see the underside, we can clearly see that the gallbladder is on the underside of it, specifically the right lobe. All right, the gallbladder itself, it is connected to the liver via our cystic duct, which basically merges with that common hepatic duct that we talked about earlier. And in terms of that merging, when it does merge, it forms the common bile duct. In terms of the layers of the gallbladder wall, it has a serous layer, it has a muscular layer, and it has a mucosal layer. So the serous layer is the outermost layer. So it's like the peritoneal covering that protects the gallbladder. Then the middle layer is the muscular layer, and it's composed of smooth muscle fibers that contract in order to eject the bile into the duodenum or the duodenum, however you choose to pronounce that word. And then last but not least, it's composed of a mucosal layer. That's the innermost layer. It's also lined with folds called rugae. And this is what allows the gallbladder to expand when the bowel is being stored or is accumulating there. So in terms of storage and expansion, the gallbladder can store between 30 to 50 milliliters of bowel, and the rugae or those muscular folds will expand to accommodate that bowel storage. So similar to the ability of our stomach to expand when we eat, the gallbladder has the ability to expand for storage. When digestion does begin, we do have a hormone called CCK or cholecystokinin that triggers that muscle contraction. So it basically squeezes that bowel into our duodenum to help with that fat digestion. So again, the gallbladder is a place where we store and concentrate bowel, and of course bowel is released from the gallbladder when it's needed for the digestion. We have already been talking about this, but we'll go ahead and talk about the functions of the gallbladder again. The gallbladder's role is not to produce the bowel. Of course, the bowel is produced in the liver, but it's only to store, concentrate, and release that bowel when it's needed for digestion. So again, the primary function of the gallbladder, one, is storage of the bowel. So the gallbladder basically is a reservoir for that bowel that's produced by the liver. It's going to hold that bowel there until it's needed for digestive purposes. Specifically, we're talking about after we consume something that is fatty, we need bowel in order to digest that fatty food. In terms of the concentration of the bowel, where we talk about fivefold to tenfold, the gallbladder does remove water and also electrolytes from the bowel, making it more concentrated or more potent for the job that it has before it, which is that fat digestion. So again, that concentrated bowel assists with breaking down those dietary fats into smaller molecules that can be easily absorbed. In terms of ejection of the bowel into the duodenum, we've already been talking about it, but when the fatty food does enter the small intestine, we do have a hormone called CCK, cholecystokinin, that's released. And that cholecystokinin signals the gallbladder to contract. When it does contract, it pushes that concentrated bowel into the duodenum via the common bowel duct. And again, this process helps facilitate fat emulsification and also absorption. So we need this bowel in order to be able to break down fats. So some of the effects of bowel flow, if there is some type of obstruction, what you might notice is jaundice development. So basically, if the bowel flow is blocked due to something like gallstones or inflammation, and if it's blocked, that means that the bowel can't reach the intestines for excretion. Instead of that bilirubin, bilirubin, which is a yellow pigment in the bowel, is going to accumulate in our bloodstream. And when it accumulates in the bloodstream, it's going to cause for a yellow discoloration, not only in the skin, but also in the eyes. So again, this occurs because the bowel is not reaching the intestines and being able to be excreted. Also, in terms of bowel flow obstruction, when there's a disruption of that normal bowel excretion, normally, again, that bowel is going to leave through our feces and give our stool that color, that brown color. When the bowel flow is obstructed, the person's stool may appear pale in color or more of a clay color, and that indicates that it does not have that bowel in it. Also, another condition that can affect the bowel, I'm sorry, not the bowel, but the gallbladder, is gallstone formation, and we call it cholelithiasis, is what we call gallstones. So we basically have an excess of cholesterol, or we can even have an excess of bilirubin in the bowel that crystallizes. And when it crystallizes, it causes stones, specifically because it's in the gallbladder. We call them gallstones. If these stones do happen to block the bowel duct, they will prevent the bowel from being released. And what it can cause, in addition to pain, it can cause nausea, and it can also cause digestion issues for the patient. So some of the larger gallstones, especially if they are blocking that bowel release, they may need to be surgically removed. All right, and here we're looking at two images. We are looking at in image A, this is showing you cholesterol gallstone filled gallbladder. So the gallstones are filling the gallbladder, and in image B, we're basically showing you a laparoscopic view. So this is the scope that we use in order to visualize the gallbladder. So basically, we're looking a little bit about the composition of these gallstones here and the visual look of them, and then also in terms of the laparoscopic view here, basically how do we surgically intervene in order to treat these gallstones that might be blocking the release of the bowel. So again, here, image A, these yellow colored stones suggest that these are cholesterol based stones, and these are the most common types of stones. Gallstones do form when those bowel components, specifically cholesterol, bilirubin, and also calcium, they will crystallize due to bowel stasis or an imbalance there. When we have multiple stones, typically they're going to be of varying size, and this indicates that we have chronic gallstone formation, which can lead to inflammation, so cholecystitis, and also these gallstones can lead to pain and, of course, blockage. All right, this one is a laparoscopic view of the gallbladder. This is pre-removal, so before we've removed the stones. So again, when we talk about um, surgical removal of gallstones, it's considered to be a minimally invasive procedure. So we call this laparoscopic cholecystectomies is what we call it. So for this particular image, the gallbladder is inflamed. It's also distended, possibly due to blockage, or it could possibly be due to irritation from the gallstones. So there will be a surgery performed laparoscopically to remove some of these gallstones. Typically, this surgery does have or cause minimal scarring, and it is the preferred method of treatment to remove these gallstones. So in terms of clinical relevance, gallstones, if they're small, we can typically pass them into the bowel duct. It can be painful or can cause blockage. If they are large, typically they're not going to be able to pass, and they can lead to chronic inflammation. Also, it can lead to obstruction of that bowel flow and also increase infection as well. If we leave this untreated, it can lead to more severe complications. And if we have these severe complications, we can potentially have, the patient may potentially need an emergency gallbladder removal. So cholecystectomy is what we call that. So again, these are just images of what gallstones look like, and of course the laparoscopic view of the gallbladder. Now we're going to talk about the pancreas, and the pancreas also has multiple functions. It plays a role in digestion via the exocrine system, and it also, in terms of blood sugar regulation, plays a role in the endocrine system. So we're going to look a little bit at the anatomical location, the structure, and also the functional composition of the pancreas. So in terms of location, the pancreas extends from the duodenum or the duodenum, which is the first part of the small intestine, and it runs behind our stomach um, until it reaches the spleen, or it reaches the spleen. So in terms of the positioning of it, it allows it to release those digestive enzymes into the small intestines and hormones as well into the bloodstream. Composition wise, the pancreas is made up of both endocrine and also exocrine tissue, as you can see right here, exocrine and also endocrine. So the exocrine portion of it is what it's mainly made up of, or the majority of the pancreas is made up of the exocrine portion, and the remainder is made up um, of the endocrine portion. So in terms of total mass, most of it is composed of the exocrine portion. So in terms of exocrine versus endocrine functions, the exocrine portion aids in terms of our digestive role. So the exocrine pancreas consists of what we call ancillary cells, and ancillary cells produce digestive enzymes. Those enzymes will travel through the pancreatic duct into the duodenum, and it's going to aid in breaking down of things like carbohydrates, proteins, and it does also assist in breaking down fats as well. In terms of the endocrine portion, it plays more of a hormonal role. So scattered within our exocrine tissues are things called pancreatic islets, or the islets of Langerhans. And these islets contain alpha cells and also beta cells. Alpha cells secrete glucagon, which helps raise our blood sugar levels, and the beta cells secrete insulin, which helps lower our blood sugar levels. So again, in terms of the endocrine function, we need it for glucose regulation and also metabolic balance as well. So again, the pancreas helps with digestion, and it also helps with controlling our blood sugar. So again, it's more of a diverse organ. Also, one thing that could help, if we can understand the fact that it has exocrine and also endocrine functions, it helps knowing this in order to be able to diagnose and also treat disorders like diabetes and also pancreatitis as well. All right, now we're going to look a little bit deeper into the functions of the pancreas. So we kind of talked or discussed a little bit in the previous slide. So this slide basically highlights those opposing effects of insulin and also glucagon on carbohydrate metabolism. So despite being produced in close proximity with the pancreas, the hormones do work in opposite directions in order to help maintain our blood sugar balance, or homeostasis, when it comes to our blood sugar. So we're talking a little bit about glucagon versus insulin. So the opposing roles that it plays in our blood sugar regulation. So we'll start with the glucagon. So glucagon, it is produced by alpha cells. And in terms of function, it raises our blood glucose levels when they drop too low. So basically what happens is it stimulates the liver to break down glycogen into glucose in a process called glycogenolysis, and it promotes glycogenesis, which is where that liver creates glucose from what we call non-carbohydrate sources. In doing this, it ensures that our body has a continuous energy supply during fasting or times when we have low blood sugar states or low blood sugar. Now, in terms of insulin, it is produced by our beta cells, and in terms of the function, insulin lowers our blood glucose levels when they're too high. So basically, glucose, when it's taken into the cells for energy, it promotes glycogen storage in the liver and also the muscles, and it prevents excessive glucose release into the bloodstream. So why the why their proximity matters, or why they're in close proximity, is because those islets of Langerhans that we talked about earlier, they house both the alpha and the beta cells, and it allows for um, localized rapid regulation of our blood sugar levels. So if one hormone is being underproduced or overproduced, it can lead to what we call metabolic disorders like diabetes or hypoglycemia. So again, the balance between insulin and glucagon is, I'll say, very important when we talk about maintaining a stable blood glucose level. Any disruptions in the balance can lead to chronic conditions like diabetes mellitus, that will require external insulin therapy or some sort of glucose regulation strategy. So again, the pancreas helps assist with the production of insulin, and also not the production, the secretion of insulin, and also the secretion of glucagon. One of them will basically lower our blood sugar or blood glucose levels, which is the insulin, and the other will raise our blood glucose level when it drops too low, and that is the glucagon. Now we're going to talk about disorders of the lower digestive tract. So the lower digestive tract can be affected by structural conditions, it can be affected by functional conditions, and it also can be affected by inflammatory type conditions. And all of these conditions can lead to disruptions in digestion or disruption in nutrient absorption. So this slide is basically looking at some of the disorders that impact the function of the intestines as well as our overall gut health. So the first thing we can talk about is the impact of malabsorption on health. So malabsorption disorders that affect the small intestine, we're talking about the ability of the small intestine to absorb nutrients. All right. If we are not able to absorb nutrients properly, it can lead to deficiencies in vitamins, minerals, and also macronutrients. And some symptoms that occur when this happens can be diarrhea. The patient may have weight loss. They may have bloating. They also may be fatigued, and that's due to the fact that they have an inadequate nutrient uptake. So again, that's a malabsorption disorder, a malabsorption syndrome. All right, the next thing is diverticulitis versus diverticulosis, and then also we have colitis as well here. So diverticulitis, and we talked about these earlier. Diverticulosis, let's start with diverticulosis. So a condition where we have these small pouches form in the intestinal wall. So basically, like if the intestinal wall is smooth, sorry, and if the intestinal wall is smooth, we'll have a pouch occur in the wall. So instead of the wall being smooth, we will have this pouch occur, and food can deposit in this particular area. So this pouch is what we call diverticuli, and it can inform in the intestinal wall. Usually this pouch can occur, there won't be any symptoms, but if, let's say, food deposits or this particular pouch becomes irritated and inflamed, this now turns in what we call diverticulitis. So it's inflamed or somehow infected. And with this, the patient can have abdominal pain, they can have fever, or other complications can occur as well. In terms of some of the functional or chronic conditions that can occur in the lower digestive tract, we have IBS or irritable bowel syndrome, which is a non-inflammatory disorder that affects motility or intestinal motility. IBS can be triggered by diet. It can also be triggered by stress, and it also can be contributed or affected by our gut health as well. Colitis involves, we're talking about itis, inflammation of the colon. So basically, if the patient has inflammation of the colon, some things or symptoms that they may have cramping, they may have diarrhea. Sometimes they may have urgency, meaning they have the urgency or need to use the bathroom. Another thing that we have in terms of functional or chronic conditions is going to be colorectal cancer or some other rectal disorders, which are right here. So colorectal cancer is one of the most common malignancies which we can often detect through screenings, which are I'll say, diagnostic in nature via colonoscopy. All right, so the earlier we can detect colorectal cancer, the better for the patient. So as we turn about age 40 to 45, that's when they suggest that we should start having these colonoscopies. All right, now we have hemorrhoids, fissures, and also proctitis. So hemorrhoids and proctitis, those are conditions that affect our rectum, and they can lead to things like bleeding, discomfort, and also pain. It can also be exacerbated by things like chronic constipation, and also if the person tends to strain a lot when they're using the bathroom. So again, early detection and also sometimes lifestyle modifications are going to help not only prevent but also manage some of these lower GI disorders. Also routine screenings like the colonoscopies that we discussed, dietary adjustments, or medical interventions are going to treat or prevent some of these things as well. Now, the last thing that we're going to discuss is some of the disorders of the liver and also disorders of the pancreas. And again, we know that the liver and the pancreas are going to help with our metabolism, the digestion of our food, and also detoxification. So disorders that affect these areas, they can lead to severe complications. They can also lead to organ failure and some life-threatening conditions that will need to be treated immediately. So one of the things the first thing that the slide points out is hepatitis. And hepatitis is inflammation of the liver, typically caused by a viral infection, whether it's hepatitis A, B, C, D, or E. Alcohol abuse as well as toxins and other autoimmune diseases as well can cause this type of viral infection. Some of the symptoms that the patient might have if they have hepatitis They might have jaundice. We talked about jaundice earlier. That's the yellowing of the skin and the eyes due to that bilirubin buildup because the body can't get rid of it. Their liver may become enlarged, hepatomegaly, leading to some abdominal discomfort based on the location of the liver. In terms of appearance of their urine and also stools, the urine might be dark in color, the stools might be pale in color, and the patient also may have a loss of appetite due to the fact that their liver is impaired. If they do have what we call chronic hepatitis, it can progress into what we call cirrhosis of the liver if it's not treated. All right, cirrhosis is the next bullet point, and cirrhosis is irreversible. It's basically irreversible liver scarring. So chronic liver damage does lead to the scarring, and it's going to reduce the liver's ability to function appropriately. So some of the common causes of cirrhosis can be chronic alcohol abuse. Hepatitis also can lead to this, as well as fatty liver disease. So in some of our obese patients, they can have fatty liver disease that can lead to cirrhosis. So some of the complications that these patients might present with or that can happen as a result of cirrhosis is going to be portal hypertension. So basically there's increased pressure within the liver's blood supply. They might have ascites, which is fluid accumulation in the abdomen, or they might go into liver failure. So basically, the impaired ability to detoxify the body will eventually cause the liver to fail. All right, the next bullet point is pancreatitis. So we're talking about inflammation of the pancreas. So some of the causes of pancreatitis can be gallstones. Basically, the pancreatic duct is blocked. Chronic alcohol use can also lead to this as well, or autoimmune disorders can also cause this. Some of the symptoms that this patient might present with are severe abdominal pain that potentially radiates to the back. They might present with nausea and vomiting, as well as fever due to that systemic inflammation. And in severe cases, it can lead to pancreatic death. We call it pancreatic necrosis, and also organ failure as well. All right, the last bullet point here is pancreatic cancer. And pancreatic cancer, unfortunately, in most cases, is a deadly disease, which is basically considered to be adenocarcinoma, which is the most common form. It's often diagnosed very late, so in some cases too late. It's basically spread. Some of the risk factors for pancreatic cancer, of course, is diabetes, chronic pancreatitis. You might have a genetic predisposition for it, or smoking and obesity can lead to it as well. Poor prognosis, again, it is a deadly disease. Some of the symptoms that may appear for this patient, especially in the late stages, is going to be weight loss, severe abdominal pain, and also jaundice. Again, there is a low survival rate in people that present with pancreatic cancer, with most cases are typically fatal within 5 years. So again, it is considered to be one of the deadlier types of cancers. Even if it's detected early, it is still challenging in terms of managing it and in terms of treatment as well. All right, and this concludes our lecture on the lower digestive tract, which is chapter 38 of your book. Hopefully, this was helpful for you. Again, if you have any questions, please feel free to email me or text me, and I'll get back to you as soon as possible.